instead of giving you a litany of things that you need to do, I finally changed it last night to say what I really, really want to say from the bottom of my heart and leave some of the logistical items out, because for that, we can always convene after this session. So let me start with some of my disclosures and straight take you to the first point I want to show you. And this is called the congruence model. If you go to any place where objectives and strategies are built, you'll see something like this. And the main emphasis of this model is that if doing research or building research infrastructure is about you and about me, it is not going to be successful. You have to put a bigger objective for the institution and their partners to become your partners. So you align your critical objectives with the objectives and capabilities of the people around you, and then with the institutional structure, and then build a culture of research. And I want to say something very profound here, which are not my own words. This is Michael Tushman from Harvard Business School, and he says, culture eats strategy for breakfast. That if you cannot align your institutional and healthcare objectives of your patients towards building a research infrastructure, it will seem like your own mission, and you will never be able to build partners around it. So, message one. Message two is that you should think about 4 different ways of building research infrastructure. Number one, scientific capability. You must start with identifying either within your institution or outside your institution source of knowledge and potential targets where you are going to apply that research for support of finances, colleagues, motivation, and most importantly, funding. What is it going to be directed to? Is it going to be industry-based exclusively, or is you going to apply to NIH or other agencies? So you should build scientific capability and an advisory board that will help you guide this. This advisory board doesn't have to be something fancy. It can be something very simple. It can be your colleague or colleagues down the floor on your hospital. Second is recruiting partners. That means people, medical students, your staff, your NPs, your PAs, your RNs. How do you mobilize someone to identify that patient in the ICU you want to recruit in your heart failure trial? Who is going to tell you? Are you going to be able to drop everything in the cath lab and go there? You need to find partners. Third is real-time research process control. I cannot emphasize more on this. Before you embark on research, make a simple Excel table that tells you what are you going to do and at what timeline, so people can hold you accountable for your words. And it also brings transparency. The fourth point is a flat organizational structure that is digitally integrated. You know, digital integration, people think of Google and something. It has to be a simple access database. But when I work with Josh Beckman and we work on a project and we put timelines around it, Josh Beckman can follow what I'm trying to do. He can see it real time. That brings transparency, and transparency builds credibility. Credibility builds your colleagues and brings them in force, and that is the most important infrastructure. So I want to say end-to-end integration and transparency is not just a buzzword. It actually is an important ingredient for research. Now, then comes the issues of logistics. Of course, your institution has to have a system to protect human subjects, certificates of confidentiality. Make sure when you accept data from people, they are reassured that it is not going to be found on my desk or in the cath lab table with some proprietary information. Be careful about it, and I think use those systems. If you set the culture that way, everybody else in your research team would align themselves to it. Now, clinical trials. Which clinical trials should you go for example? You know, I and Mana started in 2003 in Dallas, and we started with PAD and SVG and CTO. Why? If you pick up any, what we did was we went to all publications from the Veterans Health Administration, and we looked at the baseline characteristics of all of those publications. What was common was that PAD was 42%. A large number of proportion of patients disproportionately to Medicare population had ongoing bypass surgery, and a lot of them were left untreated because of difficult to treat lesions because of interventional support, and that became our mantra, and that is what we projected. So if you cannot be experts of the trade, you will not be successful in building a clinical trial network that would support it. I could have never done PCSK9 research sitting at Dallas, VA in the division of cardiology and in the cath lab. That would not be as wise. So you put all those things equal, and then is that complex human cartoon where all of this is gelling and merges together, and if you can't merge it together, you call Josh Beckman. Or I can give out his cell phone, or you call someone that you know who can help you put this all together and put this into a research consortium. The word consortium sounds big. Or what is a consortium? A consortium is a group of apparatus, capabilities, tools, and individuals. It can be 4 people and a toy, but it has to be something transparent, organized, where deliverables are defined and timelines are set. This is the structure of the XLPAD registry, and you can see how, and I'm not going to read out the names, how a vascular surgeon, an exercise physiologist, a health economist, a basic scientist, a clinical cardiologist all integrate and see that there is something for them. And if you look at XLPAD publications, we publish in all of these areas. We have outcomes of CLI, we have outcomes of endovascular, we have health economic outcomes, we have translational research, and we have put together, or tried to put together, all these partners under one umbrella. Second is that this registry engages 24 young faculty from 13 institutions, 5 women faculty, medical students 14, and 11 medical residents and 12 fellows who are first or second authors of most of these publications. Finally, I want to say the ultimate research infrastructure are the people around you. So build a shared vision, shared objectives, shared projects, shared processes so everybody can follow, and that will lead to shared glory. And for all the logistics, and I'll show you some slides about it in the last few minutes, my message to you is form partnerships and establish network. Message number 1 as an infrastructure. View this as human capital. Develop core capabilities around what you see and practice. Create objectives that are congruent with institutional and health improvement goals of your patients. Finally, digitally integrated. I emphasize, digitally integrated, could be an Excel file, high quality, transparent, credible research processes. That is how you will engage your partners. And for everything else, I refer you to 2 documents, or 3. AHRP document on organizational guide to building health services research. It is updated every 5 to 8 years. I read it diligently. I want to emphasize the Duke's National Cardiovascular Research Infrastructure. The website is there. And for everything that is remaining is the xlpd.org and my personal email I'll sell. And that would be a good resource to tell you what I have not told you today. Thank you very much, and thank you for supporting CVI. I hope it becomes part of your lives and ongoing professional careers. Thank you so much.